What if we could delay or even avoid knee replacement using your own bone marrow? In two powerful studies from France, Dr. Philippe Hernigou, an orthopedic surgeon, treated one knee with bone marrow and the other was replaced with the total knee arthroplasty. Each patient was their own control. And the results? Autologous cell therapy showed real, lasting impact on arthritis symptoms and joint preservation. I'm Dr. Tammy Penhollow of Precision Regenerative Medicine, a spine and joint specialist, and we're going to talk about both of these studies. They're a little bit different, but the end results are pretty impressive and are the same. So let's go with the first study. It was in the International Orthopedics Journal, and it was published in 2018. This had patients who were in the mean age of 28. They were average of 18 to 41. You're saying that's kind of young for a knee replacement, but stay with me here. It's because they had what was called osteonecrosis of the bone because they'd had so many steroid injections, and that changes the bone. What happens is we actually know that the bone is damaged. Certainly the cartilage is damaged, and we accelerate the osteoarthritis. We know that it can do things like accelerate or cause rupture of tendons and ligaments. We've seen that in Achilles. We've seen that in the tennis elbow and the golfer's elbow. And steroids are not benign. Lots of other videos on that. But let's go back to these younger patients. So there were 30 of them. That means 60 knees. And both knees were bad. It was a point where they could have had both knees replaced. So to find these 60 knees or 30 patients, they went under anesthesia, and at the same time, their bone marrow was harvested from the back of the iliac crest and spun down, and then into the femur bone, the long bone, 10 cc's of bone marrow was injected into the tibia, the lower long bone, 10 cc's of bone marrow was injected, and then they got some in the intra-articular in the joint space. On the other side, the knee was completely replaced. So they were under this one anesthetic. Things that were measured over the next several years. Well, first of all, they looked at the average MSC counts or the mesenchymal stem cell counts, the colony forming units, and they know that it was good high numbers. The range was 3,420 all the way up to 9,830. That was what was delivered. They measured perioperative outcomes. They looked at things like, how do people do? Did they get infections? Did they get blood clots? Did they like which knee over the other knee? The average follow-up was 12 years in these. The range was 8 to 16 years, and then they did the publishing. So this is the result. Anesthesia for the joint replacement side was obviously longer. Totally makes sense because it's a full-on surgery. Medical and surgical complications on the knee replacement side was more frequent. There were more deep vein thromboses, meaning where people get blood clots in the legs, and sometimes they go to the lungs, sometimes they go to the brain. Certainly they had to be treated, versus there were 0 DVTs in the bone marrow side. 6 out of the 30 replacement knees needed subsequent surgery because something happened, hardware failure, they had a fracture, there was joint loosening, etc. Versus only 1 had to have subsequent surgery who had their bone marrow knee. So they're 1 out of the 30 bone marrow knees and 6 out of the 30 replacement knees had to have a revision surgery. The knee score had improved and remained similar in the replacement side and the cell therapy side. But if you ask the total number of patients, remember I have 30 of them, 21 preferred their bone marrow knee, 9 preferred their replacement knee. So knees with cell therapy also on MRI imaging showed improvement on the cartilage and on the bone marrow lesions at the site of where those injections were done in the bone. So this was an effective procedure for treating young patients with osteoarthritis following secondary osteonecrosis of the knee. Let's take a step back and talk about what is a bone marrow lesion. Well, you can't see this on an x-ray. And normally when you come to me and we're talking about knee osteoarthritis, I want some weighted or standing films, plain films, because then I can see with you weighing, standing on it, how much joint space narrowing. This is 0, 1, 2, 3, 4, like bone on bone. But the MRI can show a bone marrow lesion either in the femur and or in the tibia, and that is thought to be the culprit because it's almost like a bruise. There is some increased signal uptake on the MRI, and that is the target for when you're placing the bone marrow into the side, and you're hoping that that bone marrow lesion actually shrinks. And I'll show you in the second study that that's exactly what happened, and they found that patients who did better did have the most shrinkage of the bone marrow lesion. So let's take a step to the next study, because this is maybe more germane to the vast majority of the listeners. These are patients 65 to 90, okay? Not those average 28-year-olds. This is 65 to 90 years old. Most of you who are listening at this point. So they had 140 adults. So 140 people means we have 280 knees. Did the same exact thing. They were just as bad. They had knees that both of them could have been replaced. And the plan was, let's replace this one, and then we'll come back and we'll replace this one. So they were all set up for that. But instead they enrolled in the study, and similar to the first group, they got one knee with bone marrow aspirate concentrate to the femur and to the tibia, and they got one knee replaced in a traditional joint replacement. And it's by Dr. Hernigou, the French orthopedic surgeon, who does an average of over 200 knee replacements every single year. He is a legend. He is one of my most amazing, I guess you would call it, mentors, because I've seen what he's done on kind of a shoestring budget in France, and he had to plead and show his case that this is actually beneficial to the healthcare system there to keep people out of the operating room and give them bone marrow lesion therapy with their own bone marrow aspirate concentrate over replacing a knee. So much less expensive, and the patients do better. So let's get into the methods here. The patients did receive the complete joint replacement on the one side, and on the other side we did the same thing where we put 10 cc's of bone marrow aspirate concentrate, your own, into that bone marrow lesion that was found on the MRI, and 10 cc's into the bone marrow lesion on the tibia. So same concept as the first. The baseline volume of the bone marrow lesions was measured because they wanted to see over time, did the volume of the lesion shrink? Did it get smaller? And how did that correspond to how did people do? And the results. Here we go. The bone marrow lesion volume regressed over 24 months at the most recent follow-up, and these guys, we had longer follow-up. So we had a 10 to 20 year with an average of 15-year follow-up. A total of 25 of the 140 patients who underwent the TKA, or the joint replacement, performed at a mean of 10-year range after the date of cell therapy. Then the overall incidence of knee arthroplasty after cell therapy, so that's your bone marrow knee, did you have to go on and have a replacement? It was at 1.19% per person year, which means it's about equal to the risk of a revision. So revisions happen when you have a primary knee replacement and there's loosening of the cement, there's failure of the hardware, there's an infection into the hardware, there's a fracture of the kneecap, etc. So no worse than a typical change after a knee replacement. Of the primary TKAs, there were 21 revisions. So those people who had the revision or the knee had to have that revised in the replaced knee. So what we found was the larger bone marrow lesions, when they were about 3 centimeters after cell therapy, was a strong independent risk factor for having to go on to have a total knee arthroplasty. So that is important, and that's something that we're now measuring on MRIs when we say, what do I think the likelihood is of you undergoing successfully bone marrow aspirate concentrate to your knee to help you avoid or certainly prolong a replacement of that joint. So that's one good thing. And that was regardless of the stage of OA, osteoarthritis. You could have a grade 4 bone-on-bone osteoarthritis, but if your lesion was only maybe a centimeter and a half, you did well, versus if you had a grade 2 osteoarthritis and the lesion was greater than 3 centimeters. So something to be looking for, and why I believe we need MRIs in addition to standing films on osteoarthritis patients if we're looking at using your own cells. I think this is exciting. I think that the patients who had the knee replacement had more complications. Well, we know, I looked at the results, they have more complications like in the first study. They had revision surgeries, they had infections, they had thrombophlebitis or deep vein thromboses, and they had ongoing chronic pain. Versus people, if you ask them, do you like your bone marrow knee better or do you like your replacement knee better? The majority like their bone marrow knee better. They have their own body parts still. They've not lost any body parts. They don't have any hardware in their knee and they like it better. It feels better to them. So if you have any questions about this or if you'd like to see how this therapy may work for you, please like, subscribe, drop any questions you have for me in the comments here, and we would love to see you and see if you're a good candidate for this yourself, because I absolutely do this. I don't do joint replacements, but I do bone marrow aspirate concentrate therapy for osteoarthritis of the knee. Thank you. If you have knee pain and would like to learn more, I have a worksheet called 5 Things to Do Now to Reduce Your Knee Pain Within a Week. Go to www.kneeboostnow.com to download it for free. I'd love to hear from you, so please like, subscribe, and comment below so I can help you get out of your knee pain.